Well, first of all, what a pleasure it is to be here with you. What a robust group. I love the topic that we're talking about. Certainly, being the CEO of a hospital for many years and having multiple implementations of EHR, this is a hot topic issue for us all the time. And to think about being able to make an impact in this area and being able to improve on really gets me excited. So here today we have an exciting group of individuals that will be able to give us some insights into some of the current issues that are happening. I'm excited because we have the opportunity to hear, I think, some challenging things that will allow us to look at perhaps things in a little bit different way. Format for today, we're going to have the individuals come up and share with us. We've asked them to either talk about a project that they're working on and had some success in, or a challenge or opportunity that we have. We'll have the opportunity to hear from them first. And then I'll invite them back up on stage for some questions to go through that as well. Let me first of all run through who the speakers are. First of all, we'll hear from Erika Fry, who's a senior writer at Fortune. And one of the things that in reading her article is impressive is to look at what not only you think about Fortune magazine and being able to look at EHRs as a perspective, partnering with Kaiser Health News, to see what are some of the things that we perhaps maybe don't always see in current technology and the way that we look at the use of the EHR. So we'll look forward to hearing from Erika first. Following Erika will be Dr. Stefanie Sebok, an instructor in the Department of Emergency Medicine here at Stanford. And Stefanie will discuss the potential of EHRs and how they augment and improve medical education and assessment. We'll then hear from Dr. Ratwani, who's the director of MedStar's Health National Center for Human Factors in Healthcare. Okay, that's a mouthful. He's also a nationally recognized expert in optimizing technology for frontline clinicians and advises on safety, technology, and policies. Raj will be discussing the impact of EHRs on both safety and physician burnout. I also love that Raj was also featured in Erika's article as well, and so talk through some of the things there, I hope, as well. And then finally, we'll hear from Dr. Lance Downing, who's a faculty member in biomedical informatics and research here at Stanford. And he will be presenting on artificial intelligence and how the potential impact of that on clinical practice impacts us. So with that, let me first of all introduce Erika.
So good morning. My name is Erika Fry. I'm a senior writer from Fortune. I come from the gloom and doom contingent maybe, but I'll try to make my comments constructive and somewhat forward-looking. It's an honor to be here. So in March, Fred Schulte, a senior writer at Kaiser Health News, and I published a month-long investigation on electronic health records. This was a project that grew out of our time covering healthcare and really the observation that electronic health records and people's frustrations with them come up in conversations over and over, and often it's conversations that seem totally unrelated, like how hospitals address drug shortages or physician well-being, or billing fraud. There's always an EHR angle. And so in taking this on, we wanted to explore the impact that electronic health records have on healthcare, what these frustrations were all about, and why this very promising technology that the US government invested billions and billions of dollars on, why had it disappointed so many people? So we worked for more than 3 months on this story, interviewed well over 100 people, physicians, nurses, patients, government officials, industry representatives and employees, policymakers, lawyers, probably some of you in this audience. So you see what we published here is on the cover of Fortune. For our April issue, it was 16 pages, which is very long for Fortune. It actually got tremendous readership. We were pleasantly surprised for a 16-page story on a somewhat wonky topic. But we think that shows that it's an important subject and one that people have very strong opinions on. You'll gather from the cover that it was not an overwhelmingly positive story. But I do want to emphasize one thing, because I've had conversations with people that I think read only a very small part of the story, or maybe just the headline. But Fred and I were not arguing that EHRs are so terrible that we should abandon them and go back to paper records. We were just pointing out that EHRs should and could be a lot better, as could the policies and practices around them. So in the story, we spent a fair amount of time exploring why we think the widespread adoption of EHRs in the US had, in our view, gone poorly. I'd encourage you to read the story for that insight, which you can get on Fortune.com or Kaiser Health News' website. But by one measure, as Dean Miner already talked about, the HITECH Act was an incredible success. And that was in a very short amount of time. Nearly every doctor and hospital in the US got an electronic health record. So you see, this is data from HHS. It goes through 2017. But currently, 86% of doctors' offices at 96% of hospitals now have electronic health records. For hospitals, that's up from less than 10% in 2008 when President Obama signed the stimulus bill. So that's a big leap forward. But what I want to focus on today is what we heard over and over in our reporting, where the ongoing challenges and where there's most room for improvement with EHRs. I don't think any of these will come as a huge surprise. The good news is that there are many people working on these issues currently. So interoperability, as was mentioned earlier, the fundamental idea that healthcare providers would seamlessly share records and really benefit from that exchange, today remains a fantasy. While the industry has made progress in recent years to facilitate sharing, and there have been technological improvements or breakthroughs which are promising, and the government calls this a priority, we have really a very basic level of exchange. And from institutions that have that basic level of exchange, there are still thornier questions about sort of the quality of the data. Can they trust the data? How easy is it to use? So those are issues going forward. I've called the next area transparency, and there was a lively discussion about this already. But while we have all these de-identified records flying around, patients really struggle to access their records, even though the law entitles them to them, and they're in a digital format now. In the story, we pointed out that even Joe Biden and Seema Verma from CMS have had these issues. And one particularly contentious issue is just how much of the record should the patient get. And Fred and I reviewed a number of cases where, people couldn't get the basic information, but there are also issues over the EHR metadata and audit trails. And those audit trails, reveal who edited the record, who accessed it and when. So that's information that could be very valuable to a patient if they've had some unusual episode of care. Attorneys call this a game changer for malpractice suits. But obviously, healthcare organizations are very protective of that and have really been fighting hard to not make that available. Usability, Raj Ratwani is here. He talked to me a lot for this story about this, and he'll, I'm sure, go into it in much greater length. But basically, users of EHRs, the frustration is very real. We heard that the systems are clunky and hard to use. Many practitioners don't see EHRs as supporting clinical care, but as a time suck that adds stress and work to their job. It disrupts the patient-doctor relationship. And while this comes down to how vendors design their products, it also comes down to how providers implement the systems. Lastly, safety. Obviously, this is very related to usability. When the technology is not intuitive, easy, or pleasant to use, there will be user errors, and the mistakes can be dangerous for patients. We know these mistakes are happening, and we know they're understudied. So we really don't have a good handle on the safety record of EHRs. We know they have made medicine safer in numerous ways, eliminating handwritten errors, preventing the medication errors that Dean Miner mentioned. But we also know that they introduce new kinds of mistakes. Users click the wrong thing, or the information gets put in the wrong record. Sometimes there's so much information that physicians miss relevant details. Fred and I reviewed a number of cases for the story where these issues resulted in harm for patients. You can't blame the mistakes on the EHRs exactly. It's a user error, but the mistakes are related to the way these systems are designed and implemented, and they're preventable. No one wants to be making these mistakes. So experts also pointed out to me that these errors are different from ones made in the paper era, and that they can be harder to catch and further reaching, and sometimes systemic because they become embedded in the computer. People also say we've lost the safety infrastructure in healthcare settings that existed before with the move to computers. We communicate less, and some of the double and triple checking that existed before that helped catch errors has disappeared. How many of these errors are occurring? We really have no idea. We heard quite different opinions from people we talked to. Some don't think they're a problem and that they're anecdotal. Others say, this is like a silent epidemic within medicine. The majority think it's somewhere in the middle, but that we should be studying it more. Sorry. There is no organization counting or tracking such errors or safety issues with EHRs nationally. What we do know comes from fairly small data sets from academic studies, patient safety organizations. This here is a data set that Quantros, which is a private firm that tracks issues for healthcare organizations, provided to us for the story. So you can see that, I guess some of it got cut off at the bottom, sorry about that, but the number of errors has increased over the past decade, and the person that spoke with me from Quantros says that she thinks there are many more, that they're underreported and often not identified as health IT errors. There's been a debate over the years about how best to address this issue. There has been a fairly broad consensus that a public-private partnership model, an organization like the FAA or NTSB would be a good model for health IT. ONC tried to lead that effort, and in 2015 got so far as to commission a consultant to draw a roadmap for the Health IT Safety Center that still exists on the internet. But the center got stalled when ONC's authority was questioned. So at the moment, Fred and I have more reporting on this that's forthcoming, so stay tuned. But from what I've heard from people, it's really upon Congress to act and do something. Those that I interviewed for this story really expressed a sense of resignation. They don't expect that will happen. And to end on a very dark note, sorry about this, they really think it will take a major health IT disaster, something on the scale of like a Boeing MAX crash within healthcare to get people to act on this. So hopefully that is not what it will take, but thank you for the time.
So thank you very much for inviting me to speak here. And I was thinking as I was coming into work this morning that I started at Stanford last year, and the first event that I attended was actually this EHR Symposium last year. So I'm super excited to be able to talk to you today. And I'm going to talk to you about the opportunity of using electronic health record data for educational purposes. So for those of you who are unfamiliar, within medical education, we are currently undergoing a paradigm shift. And what that means is we're moving away from the traditional time-based cohort models in postgraduate training to competency-based models. And what that means is that learners will progress throughout their graduate training based upon their ability to demonstrate competency on particular outcomes. And so this is a huge undertaking, and this also means that we need more data about what learners are actually doing in the clinical workplace. And so thinking about this as a problem and thinking about potential solutions, I found myself wondering whether the EHR could be a window into understanding trainees' clinical performance. And so when I started out with this work, the first thing I did was adopted qualitative research, embraced it, and went and talked to faculty and residents from over a dozen different specialties. And I asked them this very simple question: what are your thoughts of using electronic health record data for this purpose? And they had a lot to say, and we published this work earlier this year in Academic Medicine. And I want to just read to you some of the quotes of what the residents felt in terms of using the electronic health record data for this purpose. And so one of the residents that I spoke to really thought it was a great opportunity to summarize everything that they're doing in the clinical workplace. And she went on to say, wouldn't it be great if the supervisor could say, I noticed that you always order antibiotics for 3 weeks instead of 5 days. Maybe we should go over dosing regimens or frequency regimens for antibiotics. And maybe that could be a personal learning point. Other residents went on to talk about how the EHR and the data that's contained in there about clinical performance could be used to help them understand where they are throughout their postgraduate training in terms of their progression. So this one resident said, I think it's helpful to know whether you're performing at the same level as your peers on certain metrics. I really struggled with that sense because I didn't really have a cohort that I went through all my years of training with, and so it was hard to know, and I just kept asking myself, am I on the right track? And I felt like I wasn't getting any feedback to confirm or deny whether I was progressing as expected. And so in general, residents and faculty were really in favor of using the electronic health record for this purpose. But one of the other things that they noted was that the electronic health record is not going to be the be-all, end-all for assessment, and that there are gaps that we need to pay attention to. So I'm going to read you this quote from this resident from obstetrics and gynecology. She said, I can see the utility because it seems very objective. It just doesn't tell the full picture. It doesn't capture how long I spent at a patient's bedside talking to her about the possibility that her baby might be born severely prematurely. I can't think of a mechanism of capturing that in the EHR from a meaningful way. And so taking this information, I decided to do a deep dive, and I chose emergency medicine as the specialty to do that deep dive. And again, I went back and I interviewed faculty and residents, and I asked them this question: what data in the electronic health record would you like to know about? Like, I'm going to go in and I'm going to get you stuff. What do you want me to get for you? And so they gave me a nice list of, well, I'd like to know about this, I'd like to know about this, and I'd like to know about this. And then I took all of that and I developed a prototype resident report card for emergency medicine residents. And I don't have time to share all of it with you today, but I'm going to share with you a single metric so you can get an understanding of kind of what we did and how we did it. And so the metrics that I'm going to share with you here was the time to fluids and the time to antibiotics for patients who had been identified with sepsis. And so you've got 3 lines here, and the purple line represents the clinical guideline for this particular disease, which suggests that if patients receive fluids and antibiotics within 1 hour, their outcomes are generally better. And so what we see here is we see the resident and we see when they met this guideline and when they didn't meet this guideline. And I must say, one of the most challenging things about doing this work was actually figuring out what the appropriate unit of measurement was for residents. So we do report cards for faculty, and sometimes you get them monthly, sometimes you get them quarterly, sometimes you get them biannually. But that just really didn't seem to work for residents because they're on a different schedule. They're rotating. They've got different blocks. And so that's what we ended up doing, was we ended up breaking down the EHR data by block so that it represented what the resident was doing on each of the rotations. So a resident could look at this data and then interpret, where was I in block 4? Oh, that was my team. That's how I was able to meet that guideline. And so one of the other things that we did that was really interesting and I think is super important was we looked at all of the cases. We wanted to acknowledge and give kind of credit to the resident that they are not solely responsible for some of these performance metrics. Anybody who works in healthcare knows that it is a team sport. And so what we did was we identified situations where fluids were ordered and given by another team member before the resident even got a chance to see the patient. And doing this was also helpful because it allows the resident to gain some insight into what affordances are provided by other members of the interprofessional team. And it also allowed them to see what their role is in the overall outcome as opposed to feeling the need to take some responsibility for a particular outcome. And so here are my fabulous residents from emergency medicine. And when you think about why all of this stuff matters and why we need to do this, it's because we need to individualize our education. We need to be able to provide learners with timely, constructive, and specific feedback about their clinical performance. And the EHR actually allows us to do that. And so as we move forward with this vision of precision health, where the right treatment gets to the right patient at the right time, we also need precision education and assessment, where the right feedback gets to the right learner at the right time, so that we're not just leveraging the EHR and its technology, but we're also leveraging the human capital of our trainees, which together will ultimately result in better patient care.
Great. Well, it's an absolute pleasure to be here today. And I'm going to spend the next 10 minutes or so doing a deep dive into a couple of the topics that Erika Fry had brought up, and specifically on usability, and talking about the implications of usability for both safety and for burnout. Now, most of you have probably experienced some of the usability challenges with health information technology, specifically with electronic health records and with patient portals. And there's actually, believe it or not, a formal definition of usability. So when most of us think about usability, we sort of have this fuzzy sense of what it is. There is actually a formal definition, and that formal definition is it's the extent to which we can use, in this case, the technology, efficiently, effectively, and satisfactorily. We can actually measure those things. So efficiency, we can measure time. Effectiveness, we can measure errors. And there's all kinds of survey instruments for satisfaction. And that's all well and good. But I want to spend a little bit of time really demonstrating the way we should be thinking about usability. And pictures worth 1,000 words or 10,000 words. This is one of my favorite ones. So this was taken by the late Bob Wares, who's an incredible emergency physician, researcher, and mentor. And it's pretty striking. What do you all see? What's everybody looking at? There's this really pretty, very expensive piece of technology on the right side of the photograph. And this $50, maybe $100, probably a 3M whiteboard, dry erase board on the left-hand side. And what's really nice about this picture is, number one, it dispels most myths around technology. So we sometimes hear, this is a generational issue. The young and the old are looking at that. There's some gender differences here. Everybody's looking at that. There's also a fax machine in here, so let's not talk about that piece. So why are people using this dry erase board and not that beautiful piece of technology on the right-hand side of the photograph? Well, it's because it doesn't actually support the way that they do their work. And if we think about the way that dry erase board came to be, it emerged from the way that team does their work, and it was built over time. And there are all these different cognitive artifacts, indicators on there that have meaning to the care team. Environmental services might put a little circle next to an empty circle next to a patient and a room number to indicate that it hasn't been cleaned yet. Then they might put an X there to indicate that it has been cleaned. The physicians have a way of using this. The nurses have a different way of using this. So when we think about usability, I like to always think about it in terms of having two different components. The first is what we call basic user interface design, What's nice about this is it's context independent. There's a 50-year history of science, even longer, telling us exactly what to do here. So when I say context independent, whatever we do in healthcare with electronic health records are the same rules that we should be using for the visual displays of vehicles, the same thing we should be doing in avionics, the same thing Amazon does. Basic rules. We're now starting to get there with electronic health records, so that's the good news. But the second piece of this, and the more difficult part, is what we like to call context-dependent components. This is the really hard stuff. This is how do we build this technology to actually meet the needs of our clinicians and our patients. So the way we build the technology for oncology is probably going to be different than the way we do it for emergency medicine because there's completely different workflows and practices. This takes a lot of time. This takes a tremendous amount of investment. Now, usually when I say that, someone in the audience throws something at me and says, we've already invested $40 billion. Yes, we did invest $40 billion. And that $40 billion was intended to get us to adopt EHRs, which, as Erika shared, we did. And now we need to start optimizing these, since we didn't do it before, to make it work for patients and clinicians. So as you think about usability, think about those two different components. Now, what I want to do is I want to share some information with you. How did we lose that? OK, we'll pretend like there's text in the middle. I want to share some of the studies that we've been doing, really highlighting the connection between EHR usability and safety. So one of the first studies we did is we looked at a database of almost 2 million patient safety event reports. If you're not familiar with patient safety event reports, these are typically reports entered by a frontline clinician that indicate either a near miss or a serious safety event. So it can range from almost administering the wrong medication to a patient all the way to we operated on the wrong side of the patient. And what we did is we took a very conservative approach of analyzing these data to identify EHR usability issues. So what we did is we searched the text and we looked for an explicit mention of one of the top 5 EHRs. So the reporter would actually have to say, I was using product Zeta, don't look up Zeta, it's not an EHR, and I mistakenly clicked on the wrong part of the interface and ordered double the dosage that the patient was supposed to get. So we filtered it down by that, and we looked at ones that were specifically indicated as resulting in patient harm. And then we had our coders read through all of those and identify what the usability issue actually was. And what we found is we filtered down 2 million, it went down in that middle block, was supposed to say about 2,000 reports, and then down to 557, again, a very conservative approach, and you can see the kinds of usability issues that were most prominent. The top 3, data entry, difficulties actually entering information into the system. The second, alerting. The third, interoperability. That's all well and good. We were hoping that would help move policies to improve the safety of these electronic health records. That didn't work. So if you really want to sell something to Congress, focus on children. So we repeated the study, this time with pediatric populations. And we partnered with the Children's Hospital Philadelphia and the Children's Hospital Wisconsin, and we took a very similar approach. This time we focused specifically on medication events. We used natural language processing to identify high likelihood health IT or EHR related events that were medication related, and we coded all of those. And what we found is that a third of the 9,000 that we started with tied back to an issue with the electronic health record, and specifically a usability issue. And 609 of those actually reached the patient. That's 609 children whose lives were potentially impacted because of the usability of an electronic health record. Now, I know Dean Miner early on said we're looking at the future. I promise it's going to get better in the next couple slides. So the last piece I want to talk about before we talk about the bright future is what's happening on the ground today. So we recently completed this study where we went to 4 different sites, 2 on Epic, 2 on Cerner. We looked at the EHR that they're using today. So we went to their site to have this study done with them interacting with the technology they use today. And we focused on emergency medicine physicians, both residents and attendings, and we had them complete 6 different clinical scenarios. And we recorded everything you can imagine. Eye movement data, so we could see where on the interface they're looking, mouse clicks, keystrokes, you name it, we grabbed it. And if you look at the data on the usability and the errors, it's staggering. So take something like a very simple X-ray, left elbow, wrist, forearm. If you look at the different sites, and we've washed the vendor names because this is not about a specific vendor, this is about the state of the technology today. If you look at the variation, for example, look at the X-ray vendor A, site 1, 31 clicks to order the X-ray, yet the next site, it's on an average about 8 clicks. Huge variation. And then you look at the error rates, look at something like a prednisone taper. In this case, we asked the physicians to reduce by 10 milligrams every 2 days for 12 days. The first observation is, guess how they actually did the math? They pulled out their phone and they used the calculator, or they asked for a piece of paper and did the math by paper. Not a single one of the 4 sites, nearly 60 physicians, had a capability to do the math for the taper using the electronic health record. Not a single one. Widely used systems across the country. Up to a 50% error rate when ordering a taper. Now, thankfully, we have a resilient healthcare system. And while an order might be placed that's incorrect, it gets caught through this nice, resilient system. So that's a quick snapshot of where we are today. Now, the reason I bring this up, and specifically focusing on this variability between sites, and by the way, if you look at a specific site, there's huge variability between physicians within a specific site, is we tend to often think about blaming the EHR vendor or developer and saying this is all a vendor-developer problem. But what we're seeing with these data is that there's huge site variability and that we have to start thinking, and more institutions are thinking deeply about the implementation side of this. So how are we configuring and customizing this? And I want to give you a concrete example of it, and it's deliberately an ugly slide. One of the cases in that study I just talked about was to order an MRI cervical, thoracic, lumbar. If you look at the left side of this, in one system, one physician has to select MRI, order cervical, they search for MRI cervical, they have to select it, and they have to type in a reason. Then they have to do the same thing again for thoracic and the same thing again for lumbar. Yet you go to a different site, and there's this order set. They just select MRI, ED, and they get everything lined up for them. So it's a great example of how if we make the investment at implementation and optimization, we can actually make some pretty significant improvements here. So I said I would end on a positive note, and I want to talk about some recent work that we did with the AMA, and we launched this in February of this past year, of 2019. So it marked the 10-year anniversary of the HITECH Act. HITECH was passed in 2009. This was released in February 2019. And there's still a lot of letters missing here, which is very odd. So we came up with a great slogan. I'd love to take credit for that, but it was actually Mandy Dorn on our team that did that. Electronic health record, errors happen regularly, everyone has responsibility. And the goal of the site was to raise awareness of these kinds of issues that we're seeing today. And for the first time, to show explicit examples from the study that I just described of what interactions with the EHR actually look like. So if you go on the site, for example, you'll see a physician interacting with the EHR, trying to order Tylenol, 86 different options for Tylenol, many of them irrelevant for the particular patient that they're looking at. So with this site, we're hoping that it increases transparency, and we have specific calls to action, and I want to quickly cover 2 of those. The first is to really improve usability and safety, we have to get rid of what are called gag clauses, which prevent the explicit sharing of images, screenshots, videos. The ONC, the Office of National Coordinator, is moving down that pathway and has that in their proposed rule, and we're hoping that that stays in place. That's only one step. The next thing that needs to happen is we have to have a central reporting system, just like we do for medical devices, medications, and many other things that impact patients. Until we have that and can actually connect information across the country to identify these issues, we're going to continue to struggle with one patient being harmed by EHR an issue in California, the very same issue existing in New York, and a patient being harmed over there. So there's a path forward, and I'm hoping we get there. Thank you so much.
Hello, everyone. It's a real pleasure to be here today and speaking with all of these amazing people focused on the same common goal of improving where we are today. So I'm going to talk a little bit about some of the themes I believe are important and some of the pressing issues, particularly on the provider side, recognizing that this still is all about patients, and some of the efforts that we're leading to improve this. I think a level setting is to understand some of the fundamental problems and where our providers are spending time today. Krasinski and others at AMA led this really foundational work using a really difficult but important methodology of time and motion. And so literally following doctors around in their practices to understand what is it that they do in a day, because before 2016, we didn't really know. And I would say this is probably just the tip of the iceberg, but from what we learned from here is that we're spending a lot of time in the EHR, and relative to the patient-facing time, it's probably as much or more. Follow-up work by Ming-Tai Seal and others in San Diego, looking actually at a Sutter location nearby, used EHR audit data, so maybe a more efficient mechanism, but a little bit less granular. And I think the two things that are important from this is they both supported the findings shown in the AMA study, and then also noted, how much time we're spending typing notes, which is kind of a horrific idea that for all of our time spent in front of high technology, most of the time we're practicing our keyboarding skills. We looked at an international cohort, and we wanted to understand what are some of the differences between US institutions and international colleagues, all using the same vendor, so kind of vendor agnostic. And what are some of the differences that we can peel out, and what might they reflect? And what we showed here is that on average, in the United States, our doctors write notes that are 4 times longer than our colleagues abroad, and not a single US institution was writing notes as short as our international colleagues. And so I think this is just, again, a hint of some of the problems. We hypothesized several different mechanisms and postulated that there may be various solutions, but I think, again, this reflects the paucity of information that we have about what the actual problems are today. Very recent work done by a number of institutions looking at a model for how EHRs may contribute to burnout. I think there's a lot of perceived or anecdotal evidence that there is burnout associated with EHR. I'm not entirely convinced, and I think this study was the first to really address this in a rigorous manner. And long story short, I think the answer is there are some usability issues. There are also just general professional issues that are contributing to burnout. But I think interestingly, again, 2 things that came up was that data entry, typing notes, and then looking for that information subsequently were both dissatisfactions. I think this brings me to something that we all need to acknowledge, at least at a high level. It's probably not the end of the conversation, but I think an important theme. David Blumenthal, after his time leading the ONC, was quoted stating that fee-for-service will always distort the use of electronic health records, and that we can imagine that in a different environment, we might not have needed federal incentives to adopt them. Most other countries do not have these, and we might have very different systems today. And so I fundamentally believe that electronic health records are really a reflection of our environment and the biggest levers, reimbursement being a significant one, that drive decision makings at the health institution level today. And I'm really glad there are people that are helping move our country and generating bipartisan support to move us from a volume to a value-based system. But like those of us who are stuck on 101, this doesn't help us today. And so I think there's important work that we can do in academic institutions, in industry, and in collaboration, most importantly, to move us to a better place sooner as we await this massive transformation that will undoubtedly take decades. So I think there's been a lot of excitement around AI. It's maybe the most hyped word today, and part of the reason I put it in the title. And I think there's some genuine reason for excitement. We've seen from dermatologists and computer science here at Stanford that computers can accurately determine whether or not a skin lesion is malignant. Colleagues at Google have done work around diabetic retinopathy. I think you're going to hear a little bit later from one of our radiologists, Dr. Lundgren, about automating radiology interpretation. And I think all of that is great, but fairly narrow use cases, and doesn't fundamentally address some of the questions that we're all interested here today. Issues around burnout, usability, and the difficulties that our providers are facing on the front lines every single day today now. So a little bit about the work that we're doing. We're collaborating at Stanford Medicine here with folks at the Harvard Business School to get some insight from people who are maybe not frontline users, but have higher level perspectives and can borrow models from other industries to help us better understand how we can transform our current state to a better one sooner. We're looking at data from over 300 institutions, which I believe has never been looked at before, and understanding high-level important differences in institutions and trends across that can help us inform where to prioritize our efforts. So just two examples that I think tie together both the frontline problems and roles for technology, whether AI or not. We see that kind of normal distribution, but a lot of folks spending time on notes, which we knew before, but I think this affirms that it's not just a problem at a few practices, but a problem across the US. And I think you'll hear a little later today about efforts to employ AI to help our providers write notes more efficiently. We're also very interested in another project with a local technology partner, thinking about the problem of how do we surface information better. We know that EHRs are transactional systems. Each encounter generates a new chart, essentially, stamp in time, but it doesn't help us put together a longitudinal record and a picture, a synopsis of what the patient is really like in front of us. So we're interested in leveraging technology, AI or other, to improve the way that our doctors, our nurses, our providers can access information about patients and maybe help patients understand their conditions better. They probably understand their symptoms well, perhaps their medications, and maybe individual diagnoses. But I suspect a lot of our patients, particularly those with complex medical conditions, don't really have a full picture of their health either. And so I think a basic framework that we're applying is really starting with understanding what the nature of the work is that our healthcare providers are doing, because I would say that there's still a lot of unanswered questions about what that really is. Understanding why we're doing work. Why am I coding different ICD codes? Why am I entering their smoking status? Is it for patient care? Is it for billing? Is it because a regulatory body requires me to? And then I think perhaps most unexplored question is, what is it that our clinicians really want help with? We hear the grumbling, we hear the concerns about burnout, but I don't think we've heard in a rigorous method what is it that they really want help with in their daily lives. And then looking at both policy solutions, and then the area I'm really interested in is identifying both technology and ways of leveraging the team to address these problems. So we're going to conduct, in collaboration with colleagues at the design school here, implementation science, and human-computer interaction, an ethnographic approach to understanding this, and basically just answer the question, what is it that doctors do? What do they want help with? And where can technology fit? And I think we can expand this beyond doctors, but apply this to all of other healthcare professionals, and then start to think about how does this apply to patients as well? What are their most unmet needs, and how can we meet them, not through policy that's going to take a decade or two, but through changing the way our workflows work today and using off-the-shelf technology tomorrow. Thank you very much.
A few minutes for questions, and please have a seat. Raj, I do wish I had seen your slide, though, ahead of time. We've just built this $2.1 billion hospital with 60-inch screens in each room. I could have just done a whiteboard. Darn it.
We could have saved you a lot of money.
I could have saved a lot of money on that. Well, we really appreciate the thoughts, and I think some thought-provoking perspectives on some of the things that we're working on. Erika, maybe let me start with you. I think as we think about some of the challenges that we have, and I appreciate the article and some of the things that it raised in terms of things that we're looking at probably even on a daily basis, but why hasn't more been done? Why haven't regulators perhaps seen this as more of an issue? Why haven't we as community or as individuals seen this more of an issue? And what do we do about that, so to speak?
I think there are many factors. One, it's really complex. If we're talking about safety, I think it's hard to parse errors. There are lots of medical errors are there are often many different factors, and health IT's role, you really have to do a deep analysis of the situation, and so people aren't really aware. Raj and I were talking about this beforehand, and then just, I think it's really an awareness, and there not being urgency.
Mm-hmm. Yeah, and I think we all probably have some onus in that, and what do we do about that? Raj, you have a great website. I was taking some time to go through that this morning, and I can't remember what was in the article or your website that suggested that of the 86 ways of delivering Tylenol, one of the mistakes was to give it as a suppository. I hope I don't have that one when I'm in the hospital. Would not be good. But as we think about that, as we think about some of the things that we're looking at, you identified some ways in which we could identify errors, identify opportunities. I mean, as health system leaders or as individuals that are addressing this, what should we start with? What things should we start to identify in our own organization even before, so to speak, some of these national standards come out?
Yeah, it's a great question. So in the couple papers that I talked about very, very briefly, one of the goals was to highlight where we think the most prevalent issues are. And I know we went through those slides very quickly, but we certainly see a lot of issues around medication ordering and medication administration. That might not be new news to the folks in this room. We know that most issues are around medications, but I think starting to do some kind of risk stratification based off of the data that you have is the key to success here. And so we're often looking at patient safety event report data. We often look at ticket or bug data that gets reported by our clinicians. So those are two great sources. We obviously look at legal claims data and try and triangulate. We sometimes add in patient grievance data or patient complaint data. And then the other part of this, which we're really excited about, is work looking at actual physician or clinician interaction with the EHR to identify near misses. So there's some work by Jason Edelman who looks at the retract and reorder tool. You might order on one patient, cancel, and order on another. Dr. Zach Hedinger, the medical director of our center, has been doing something very similar, looking at, you mentioned, wrong route errors. And then what Dr. Hedinger has done is he's backed that up with, we have actual Citrix session recordings of the interaction with the EHR. So we are essentially using these algorithms to trigger when an event happens, and then we're going to look at the video to see what the actual issue is. So by combining those different data sources, I think you can start to identify where the major risks are, and then you have to go through the optimization efforts to actually solve them.
Yeah, great. Stefanie, one of the things, obviously, we're an academic medical center here at Stanford and train a lot of residents, and becomes an important component of who we are as an academic center. EHR data obviously is an important aspect of that, as you shared, and I appreciated the fact that you could actually block, because we worry about it as residents take different rotations, understanding who's on service at the time. But part of what I wanted to look at is how do you suggest we, so to speak, individualize that learning for that resident, and really using what is a powerful tool with the data and perspective to be able to individualize that for them. We certainly know our residents coming out now much more data savvy, much more electronic savvy. How do we use this to really help them?
So, I mean, I think where I'd like to see this go, and if people from Epic and Cerner are in the audience, here's my pitch to you. I'd love to, in the same way that you open up your physician dashboard and you can see all of that information, I would love all of this data to be real time so that a resident can open it up and they can see, and much as the panel was talking about before, that it's real time, it's getting populated, and that learners can then, at the end of their shift, rather than worrying about trying to get someone to fill out a form or, can you evaluate me on this? You can just sit down with your supervisor or your preceptor and say, what happened here on this shift? Because then you're dealing with whatever it is that you want to improve on right in the moment. And you've got that tangible data, and you've got the starting point for some feedback and a dialogue to occur right in the moment, as opposed to, remember that shift when we worked together way back when and this thing happened. You can just do it in the moment.
Yeah. Anything real time, yes, that always, I think, resonates very well. Lance, let me just maybe follow up on some of the applications of AI. And like you said, it's probably one of the most overpopulated words. And I love the fact that could we really make EHR data real time? That was just suggested in terms of the way that we learn from that. But if we think about it, what should we as health system and researchers do to use the EHR data and apply that in AI in something that we could actually be useful for us. What suggestions would you have for us?
I think that's a great question that so many institutions are struggling with. How do you take the advances on the research and technology side and really transform them into healthcare delivery? I would posit that Stanford Medicine is maybe a leading example of this, as we're starting to cross that bridge between healthcare delivery and pulling from the best of our amazing researchers here. And I think the way that can be facilitated is support and enablement of data access and timeliness, resources to process and clean it so it can actually be used. And then I think bringing researchers into the fold to understand, for example, your priorities as a health system CEO. What are the things that you care most about? What are the things that are most important for our patients? Because I would say our researchers are interested in this, but don't know those answers. And so I think, really just coming together and having mutual understanding and supporting some of the legwork that's required to get those in, and then starting to actually do. And I'm excited that I think Stanford Medicine is going to be starting to do some of these in the very near future.
Thanks. I know we're quickly running out of time, and I don't want to get in front of the break, but Erika, can I end with one question with you?
Sure.
I appreciate it because are there good things in EHRs? I appreciated the first one you threw out was, at least we all have them now, or 96% of us. Are there any other things that we should take away as highlights of, as systems who invested a lot into these, what are some of the good things that we should anticipate come out of them?
I think there's a ton of technological development with APIs that people are really excited about. Patients really want their data. There's just so much happening that I think the EHR is going to have to get better. So
Yeah.
I just think, there's signs that things will improve.
Yeah, thank you. Well, could you join me in giving our speakers a round of applause for their...
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.